Good afternoon, everyone. Welcome and thank you for joining us for CHADD's inaugural virtual Lunch and Learn series, brought to you by the Public Policy Committee of Children and Adults with Attention Deficit Hyperactivity Disorder, ADHD. I'm Tanya Murphy, co-chair of CHADD's Public Policy Committee, co-chair of the Advocacy Subcommittee of CHADD's Public Policy Committee, and a proud member of CHADD's Board of Directors. CHADD is the largest ADHD advocacy organization representing the at least 17 million children and adults with ADHD in the United States. We operate the National Resource Center on ADHD, funded by the CDC, as the clearinghouse for evidence-based information on ADHD. And additionally, CHADD publishes Attention Magazine. To foster a deeper understanding of ADHD and its comorbidities, CHADD has initiated this Lunch and Learn series. Through this series, we aim to raise awareness, provide education, and offer clarity about ADHD. We will discuss its impact on individuals and communities and highlight the critical importance of proper diagnosis and treatment. On behalf of myself and my public policy co-chairs, Ingrid Alpern, JD, and Dr. Jeffrey Katz, thank you so much for joining us today. We are really glad that you are here. Now I am pleased to hand over our event to our moderator, Trent Ulrich, a member of the CHADD Public Policy Committee and co-chair of CHADD's Advocacy Subcommittee under the Public Policy Committee. Trent?
Thank you so much, Tanya, for the introduction and for all of your time and effort organizing this event. As Tanya mentioned, my name is Trent Ulrich. I'm a member of CHADD's Public Policy Committee and a co-chair of our Advocacy Subcommittee. I have ADHD, and I joined CHADD in early 2023 when I, like so many others, could not get my medication because of the nationwide shortages. I'm honored today to participate in our first public policy virtual Lunch and Learn, a new quarterly webinar series designed to educate legislators, congressional staff, agency representatives, and other relevant stakeholders about ADHD and the policy issues related to ADHD. Each of our Lunch and Learn sessions will focus on a different priority of CHADD's Public Policy Committee. Today's topic, what is ADHD, how it affects children and adults, hits on our priority of promoting the widespread education of key ADHD stakeholders. Now, at this time, it's my pleasure to introduce our featured speaker for today, Dr. Max Wiznitzer, co-chair of CHADD's Professional Advisory Board. Dr. Wiznitzer will lead a presentation on today's topic, followed by a Q&A session with Dr. Wiznitzer and members of our Public Policy Committee. Dr. Wiznitzer is a pediatric neurologist at Rainbow Babies and Children's Hospital in Cleveland, Ohio. He is also a professor of pediatrics and neurology at Case Western Reserve University. Dr. Wiznitzer has a long-standing interest in neurodevelopmental disabilities, especially ADHD and autism, and has been involved in numerous local, state, and national committees and initiatives. He is on the editorial board of Lancet Neurology and Journal of Child Neurology, and also lectures nationally and internationally about various neurodevelopmental disabilities. Thank you, Dr. Wiznitzer, for taking time out of your busy schedule to join us today. I turn it over to you.
Thank you very much. Let me just share the screen and get us moving. I changed the title just a little bit because really at the bottom line, what we're really talking about is what is the impact of ADHD across the lifespan? And in order to understand the impact across the lifespan, you actually have to understand ADHD. Here we go. First, my disclaimers and disclosures. I'm a member of CHADD's board of directors. I'm a co-chair of Professional Advisory Board. There may be a discussion of some off-label treatment options, but that's going to be minimal. Now, what is ADHD, or Attention Deficit Hyperactivity Disorder? It is the most common behavioral disorder of childhood. Look at the numbers here. While the numbers are ranging here between 3 and 10%, the most recent surveys from the CDC find that about 10 to 11% of children either have the diagnosis or have had it at some time in the past. When you look at the adult population, probably at least half, which is about 4 to 5%, are symptomatic with ADHD features, and I'll talk about that in a little bit. It's described that there's more boys than girls who are symptomatic, although those numbers tend to morph and change to be more one-on-one as you get into the adult years. And it's important to recognize that about 40 to 80%, so we'll just say at least half the individuals, they will continue to persist into childhood with the full-blown diagnostic features. Now, in addition to that, there's going to be another group of individuals who are what we call subsyndromal. While they don't necessarily meet all the diagnostic criteria, they're still affected by the condition to a point that intervention is needed. One of my favorite slides is basically the history of ADHD. This, for people who think that this is some made-up construct, this is old, and you can look at it. It's over 100 years old. The description of ADHD-type behaviors was first described in 1902 as a morbid defect of moral control. Even before that, in the 1800s, people were writing about children who clearly had ADHD features, but they didn't give it that name. In 1947, it changed to minimal brain damage, but then we found out from autopsy and other work that there was no identifiable damage, so it changed to minimal brain dysfunction, and that condition really was an amalgam of ADHD features, difficulties with language-based learning, and problems with motor coordination. Because it was thought in the 60s that the increased activity level was the key component, it was given the name of hyperkinetic syndrome, but by 1980, we recognized that it was more complex than that. And you can see the name has changed over time from attention deficit disorder with or without hyperactivity to the name we now give it, ADHD, which is attention deficit hyperactivity disorder, as has been running. Now, when you look at the features of ADHD in the middle of this slide, which I will point to right here, we find the three key core criteria. There's inattention, there's hyperactivity, which I happen to like to call it more motor overactivity than truly hyper, because some of them are not that active, and impulsivity. But if you think about the features that are there are multiple influences that can lead to this. There are biologic influences, including strong genetics. 80% of individuals with ADHD will have a family history that it affects a first-degree relative, whether or not they've been diagnosed. There can also be environmental stressors, and I'll talk about those in a little bit. And we have to also factor in not only the tendency towards ADHD, but what the person's underlying temperament is. Are you a laid-back person? Are you a person who's quick to react, just in general? Because those features can also influence how your ADHD will manifest. In addition to that, your intelligence level and your age will influence what features are apparent. It's on a later slide. So those are the biologic features. But in addition to that, there's other influencers that can make it better or make it worse. Where you live, in terms of how your peers interact with you and what feedback they give you, the neighborhood you're in, and also can you access care? In the home setting, it's also the discipline methods that are being used. The behavior of ADHD children can be very challenging for parents, and they can be quick to resort to either negative disciplinary strategies, which usually have no real lasting impact, but may teach inappropriate behaviors to that individual, or positive influences so we can change the behaviors. It also depends on the family structure and the family's ability to follow through on interventions. So while we always think that it's a biologic disorder, we have to remember there's lots of other influences that can impact and affect how it's going to manifest. The DSM, the Diagnostic and Statistical Manual, 5th edition, which is really the publication from the American Psychiatric Association that delineates the various psychiatric disorders and how to approach them, gives the following diagnostic criteria that are present, and I'll go through them in a little bit more detail. For your developmental level, your functioning is not appropriate. Obviously, attention span for a 5-year-old who has the intelligence of a 5-year-old should be that of a 5-year-old. However, the attention span for a 10-year-old who has the intelligence of a 5-year-old is that of a 5-year-old, not that of a 10-year-old. And if we don't take that into account, we may mistakenly make diagnoses. They're overactive, they're impulsive, but the onset has to be before age 12 years. And that doesn't mean that you have to be fully syndromic, but there should be some features suggesting that it's evolving. You may not show the full features until you're 16, 18, 20, or even older than that, but it should be there. And it's not something that occurs just in 1 or 2 days. It's going on for more than 6 months, because there can be a lot of environmental and psychological stressors that can make you look like you have ADHD when you don't. Symptoms have to be present in 2 or more settings which means it's in almost all settings that are present. But it's not due to something as simple as I can't read, and therefore when I'm in the classroom, I'm not going to pay attention, but I do perfectly fine anywhere else. And by definition, a disorder has to cause a problem or impairment in socialization, in academic performance, or in work performance. In other words, it has to have a negative influence on life. The ADHD features basically, and they're listed here, they're simple to read, from basically focus, sustaining focus, not appearing to listen, not following through when you're given an instruction. And when they get older, we notice problems with organization, losing items, getting easily distracted, being forgetful, so you're late for appointments, avoiding tasks that require mental effort. As parents tell me all the time, children will argue for 2 hours to avoid doing a 15-minute task they think is too difficult for them. And these are all criteria, but we have to remember these criteria that are here are not unique to ADHD. So we always have to take it in the context in which it's presented. The hyperactive impulsive features go anything from being fidgety and squirmy, and you can read the list here, to literally bouncing off the walls, which is on the go or driven. One of the things that we always have to remember is you don't have to only be physically ADHD. You can also be verbally ADHD, which means you talk a lot. And that's what so many of these, especially the younger individuals, will do. They're very talkative, and they have to be multiple times told, basically, hold it together, stay focused, not so much talking, things of that nature. There are impulsivity criteria, which basically impulsivity means doing things without thinking. You blurt out an answer before a question is finished, you have problems waiting your turn, and you interrupt and intrude on others. There are other impulsive actions that we can recognize, but are not part of the DSM for technical reasons, which I'm happy to answer in case anyone wants to know. Because of the ADHD that's present and the impulsivity, and if it's mixed with the correct temperament, the individuals can have a low frustration tolerance and have behavioral outbursts. So it can basically lead to lots of temper tantrums and upsets when individuals don't get their way or things are not going the way they expect. They basically can get stuck. They can have basically mental inflexibility. So they insist that things have to be the way they want it to be. As a consequence of the negative feedback they get for these kinds of behaviors, they develop poor self-esteem, and many times they get rejected by peers. If they want to change the rules to a game, if they want to basically boss people around in the work setting over and over again and don't listen when they get feedback, they're not going to have good relationships with those with whom they interact on a regular basis. The consequences is negative effect on academic performance and on work achievement. They're thought to be lazy and irresponsible because they just don't follow through, because many times they get distracted by other things around them. And it can lead to antagonistic and resentful relationships within family units and with other individuals that you know. And people then interpret this as being stubbornness that's willful, and only if they would listen and behave, they would do so much better. Obviously, that's not true. We'll talk about that in a little bit. The DSM-5 has had a good change in it, in which it looks at the ADHD criteria. If you meet at least 6 out of 9 for children, it's 5 out of 9 for adults, of the inattentive criteria or the hyperactive impulsive criteria, and you have both of them, it's called ADHD combined type. If you predominantly meet the inattentive criteria, but you don't get up to the level of the hyperactive impulsive, although some of the features are there, it's called predominantly inattentive, and obviously the other way around also. These are markers of your current state. They can change. For instance, the very young children mainly are predominantly hyperactive impulsive. The school-age children are mainly combined type, and the older adolescents and adults are predominantly inattentive. It's the same condition, but it morphs over time as we deal with the other factors that occur, which is called developmental progress. So here's basically a little graph that shows you what can happen. In the preschool years, lots of ups, if they're going to be symptomatic and diagnosed, lots of upsets, increased activity level, they're not sleeping well. ADHD, many individuals with ADHD do not sleep. It's a myth that the majority of that's related to medicine. It's really related to the ADHD. They can't just unwind. They basically stress their family units. They stress the school settings. In fact, many times they're asked to leave daycares or schools. They have no sense of danger, which means they can get injured. By the time, if they manifest in the school years, it's more academic difficulties and problems with peer relations because of their impulsive actions, and they're identified as having daydreaming. In the adolescent years, much more problems with organization and with making good choices can intervene, in addition to the difficulties with focusing, the difficulties with doing things in a timely fashion. And as a consequence of that, it leads to poor self-esteem, and it may lead to risk-taking behavior and to choices such as substance use and other inappropriate actions. By the time you get into the adolescent years, the hyperactivity tends to diminish, but the other behaviors persist. And when you're in the adult years, it still has a negative impact on your functioning in the work setting, in the home setting, and basically following through with working with other people. You may still be impulsive enough to have behavioral outbursts, which can get you into trouble with your peers and the authorities. And if you talk to the individuals with ADHD, while they may not be physically overactive all the time, they'll tell you they many times have an internal restlessness that's present. There's a differential diagnosis, and we have to remember there are other conditions that can also be associated with a short attention span, can also be associated with easy distractibility, can also be associated with motor overactivity. For instance, mood disorders. If your mood is down, you can't focus well. But that's also something that's mood related. If you're extremely anxious, you can't focus because the thoughts about the anxiety are interfering with your functioning. If you don't get a good night's sleep, you get into trouble. If you've got problems with your vision or hearing, you can't focus and pay attention as well as you should. There are certain medications that can make you have behaviors that mimic ADHD. There are certain seizure disorders that, if they occur frequently enough, can also mimic ADHD, especially inattentive type, because you're blanking out and not paying attention. There's temperament issues that can do that. And one that's very interesting from research, the younger children in kindergarten, if you do the math, if I've got a child who just turned 5 years old when they start kindergarten, and compare him to a child who's maybe 5 3/4 years old, there's a significant difference in age between the two, which means there's also a significant difference in maturity between the two. The younger child will have a somewhat shorter attention span than the older child, and the younger child can be misidentified as having ADHD. So we have to be careful about that. Complications that can occur in the preschool years, a lot of oppositional defiant behaviors, which can be driven by the ADHD. By school age years, you can develop learning problems, and you can develop conduct disorder, which is really behaviors that are breaking the law and breaking societal rules. In the adolescent years, you can develop a secondary mood disorder. You can have inappropriate risk-taking and develop substance use problems. And if this behavior continues into the adult years, you have what the psychiatrists euphemistically call antisocial personality disorder, which is really basically criminal behavior. Throughout this whole time, there's difficulties with relationships with other people, and anxiety can be present as a comorbid condition, a coexisting condition whether you're 3 years old or whether you're 30 years old. It needs to be taken into account. Here's another list of some of these coexisting conditions. I'd already mentioned the sleep disturbance. Tics occur in about 10 to 12% of individuals with ADHD and need to be identified. About half of the individuals with ADHD have problems with fine or gross motor coordination skills, which means that they may be a bit more awkward in their manipulation. Frequently, as young children, they have problems with buttoning, they have problems with zipping, they have problems with tying their shoes. And even when you get to the adult years, you may find that they have some difficulties in terms of coordinating fine motor movements that can interfere with their ability to perform certain tasks if it's required from the job. And then during this time, you also have problems with executive functions. And executive functions is the brain's secretary. Tasks such as organization, tasks such as timeliness, knowing when to start, when to stop, when to shift from one activity to the other in a effortless fashion. All of this can happen. Why do we have ADHD? Well, there's lots of different reasons. As I stated before, 80% is probably genetic. Even though we haven't identified a lot of marker genes, it runs in families. Almost invariably, if you take a good family history, you find out there's someone who has the diagnosis or someone who is symptomatic. In fact, yesterday I saw a girl. Her mother goes, I knew I had it when I was a kid, but they said girls can't have it. Therefore, you can't have ADHD, which obviously was wrong. But it's something that we have to remember in that regard. But anything that insults the brain, anything that can affect the brain either reversibly or irreversibly can make you prone to ADHD, whether it's an episode of lack of oxygen, trauma, infection, effects of toxins from the outside. For instance, even before you're born, for instance, alcohol exposure for the fetus can lead to an ADHD picture that can basically affect your functioning. And as I stated, certain medications can also make you look. When we look at now, people always say, well, it's a made-up diagnosis. It's societal in nature. It never existed before. But studies that have been done have shown there are certain brain structures. There are certain areas in the brain that are associated with attention span. These are just pictures of some areas in the frontal lobes. If I can find my little marker. Here we go. In the frontal regions of the brain, the parietal regions, which is towards the back of the brain, the deep structures in the brain that basically process information, and even the balance center in the brain to some degree does things to help coordinate our attention span and keep it on task. What happened now? These areas don't stand by themselves. There are actually networks that deal with your attention. There's an executive function network. There's an attention network. And all these networks, if they're disrupted, will lead to ADHD symptoms. So it's not just one little area, but it has a reverberating or domino effect on other areas of the brain. When we evaluate individuals with ADHD, we have to make sure that as part of the evaluation, we get information from multiple sources. The standard that we try to have people do is basically filling out ADHD rating scales that can be interpreted appropriately for the when taken into the right context that would go along with ADHD. For older individuals, it may not be that easy. You may have to go to an older relative to find out. But many times there's comments written in school records about the behaviors that were present. If Johnny could only pay attention, then he would do better in the classroom setting. So that's why the term I use, pre-existing documents. So we confirmed that the features of ADHD were present during childhood, even if we were evaluating adults. And then we looked for potential causal factors, family history and stuff like that, when it presented, what age it presented, why it presented at that time, what was going on. Are there other possible reasons, as I gave you a list before, that might explain why the attentional issues are there? Are there other coexisting issues that are present that could be causing this? And then when we do physical examinations, we really do physical examinations for medical conditions that may mimic ADHD or impact the treatment. For instance, if I'm dealing with a 55 or 60-year-old, you want to make sure their cardiac status is good, and that they don't show any other features of certain other neurologic disorders that might be aggravated by some of the treatments that we use. In the younger population, you look for problems with the motor coordination, which is dyspraxia. If there's any kind of movement disorders like tic disorders that are present. A question that's always been raised is, do we need technology to make the diagnosis? And that is a topic that's way beyond what we're talking about today. But at the bottom line, this is a clinical diagnosis. It can be substantiated or corroborated by technology, but ultimately it's clinical. The story we hear, what we see in front of us, the information we receive from other parties, that's what's key for making the diagnosis. So we make the diagnosis, but then what the question would be, what do we do about it? Well, let's say, what happens if we don't do anything about it? What would then happen? Well, people claim the features fade, as I said, about 50% in adults, but many of them are still subsyndromal. If you look at adults, greater learning problems, less years of schooling, they will all graduate, almost all will graduate high school, but if they're in college, there's a large dropout rate because there's a lower graduation rate. When they get jobs, their job placement may turn out to be lower, at a lower tier than would be expected for their academic level, for their educational level, for their intellectual level. They have problems with social relationships because of their behaviors, and they've got increased risk of a lot of healthcare issues. Let's look at some of these things. From an education standpoint, there's 2 to 3 years less formal schooling that occurs because of these issues that I mentioned about higher high school dropout rate and a lower percentage of complete college. From the work standpoint, more of them get jobs in skilled work or sales versus the higher tier, better paying jobs. And when they do their jobs, their performance is as good as you would expect. I mean, for instance, I know lawyers who were diagnosed with ADHD in their adult years whose productivity markedly increased once the diagnosis was made and appropriate treatment was put in place. These individuals can be hired. There's no difference in their employment rate. It's just they don't keep the jobs because of their ADHD features. They're let go more often. From a psychosocial standpoint, if you live with ADHD features and the negative feedback you get because of your performance, you're going to have self-esteem and social skills problems. There's a greater risk of developing criminal behavior, of using illicit substances, developing alcoholism in this population. And there's a higher rate of separation and divorce when individuals who get married. And there's a decreased independence. In other words, they're more dependent on other people to help take care of them because of the limitations that they have related to their behaviors. What are some of the health issues that occur in this population? Greater risk of traumatic brain injury, accidental injury, greater risk of violence being done to them or for them because of their tempers and because of their explosive personality, of them being the perpetrators of the violence, greater risk of unplanned pregnancies and sexually transmitted infections, poor dental hygiene. And you might say to me, Dr. Wiznitzer, who cares about poor dental hygiene? As a neurologist, I can tell you, poor dental hygiene increases your risk for strokes. We also know that it increases your risk for cardiovascular problems in general. Because they don't make good decisions, there's greater rate of obesity and type 2 diabetes, greater risk of heart disease. There's poor management of chronic conditions. There's this interesting relationship between ADHD and dementia and disorders of the basal ganglia, like Parkinson's Parkinson disorder that is present. Most frightening numbers include increased suicide rate because of the low self-esteem and an increased mortality rate from a variety of the above listed problems. So when we look at this population, if we look at people who are still symptomatic according to the criteria versus those who are not symptomatic according to the criteria, and here we have this, and we look, these are the controls, and the tan are the controls. So these are individuals basically who, if you're going to be living to 59 years of age, for individuals who are non-persistent ADHD, you can look here. They only live till about 50. That means there's 8 years, 9 years less life expectancy for this population. When we look at the ones who are symptomatic, it's basically the same numbers. If you basically take the average here, it's about 8 to 10 years less life expectancy, which means 8 to 10 years less ability to really contribute to society, interact with family, and basically have a good and fulfilling life. Those are frightening numbers that a disorder as simple as ADHD can have this long-term impact on your day-to-day functioning to the point that you're not going to live as long as you're supposed to. Let's look at economic costs. The economic impact is estimated, it's hundreds of millions of dollars yearly. Why? There's the excess costs related to the education of this population, especially if they're unmedicated and untreated in general, and many times unrecognized. We expend a lot of money, and we don't get a good return on that investment because the ADHD blocks them from actually taking advantage of the education. We know about the excessive healthcare effects, but also, especially for children and for the teenagers, there have to be caregivers around more often to keep an eye on them, which means those caregivers can contribute to society in other ways. They're either unemployed or underemployed, and even when they're working, they're not as productive, they're not as efficient as they should be, so there's a productivity loss. And in the judicial system, numbers that have been offered is about a quarter of individuals in jail, in prison, in jail, will meet criteria for ADHD. That means ADHD was most likely a contributing, if not the contributing factor that led to them ending up behind bars. That's a twofold loss. One is the expense of keeping them behind bars, Number two, actually a threefold loss: expensive keeping behind bars, the injury they did to the people, the crime they committed, and the loss of a fulfilling and productive life because the ADHD ended up having them shift in that direction. When you look at the effects in the adult labor market, look at 10 to 14% employment reduction, earnings reductions about 33%. They don't make as much money as they were destined to make, and there's an increased need for them to get social assistance. These are not good numbers. These are, in fact, something that can be treated and can be managed in a way, but not doing it, these are the ramifications. What are the modifiable factors? Education, employment, driving, because there is a driving risk, increased risk of accidents. We can avoid obesity and nutrition if we intervene. We can avoid the risky sexual behavior. We can improve the sleep problems. We can avoid substance use disorder with appropriate intervention, or at least minimize it. And we can improve their overall health. Studies that have been done have shown that the use of medication reduces the amount of suicide attempts. That the appropriate use of medication improves educational outcome. Many times it's a normal educational outcome, but clearly improves it. And studies that have been done have shown that when you treat the ADHD, there's an increased risk and an increased chance of develop substance use disorder. Increased chances, excuse me. An increased chance of having driving accidents, and an increased chance of health issues, and an improvement in their ability to interact with those in their environment. So what do we do about the ADHD? What do we do about it? Well, you need a treatment plan. But if you can have a treatment plan, the treatment plan has to be done with a team participation. The patient, the family, that means those around the patient, the school environment or the work environment, plus the clinician. And the components are behavioral interventions, educational interventions. By the way, when I say educational interventions, it's not only classroom, it's also becoming informed consumers about the conditions so you know what you can do about it, as well as medical or pharmacologic interventions. What we know is that on this list of 3 potential interventions, single modality effects, which means if you just do one of them, differs between individuals. Some people benefit better from just a purely behavioral approach, while for others, they need medication before you can even do a behavioral approach. But what's the benefit of multimodal therapy, which means really using all 3 of them? One is you clearly have a good attention span. Number 2 is you can treat the coexisting conditions, because we know there's an increased rate of things like anxiety, mood disorders, tic disorders, things of this nature that can be effectively treated in this population. 3 is you don't need to use as much ADHD medication if you also teach them good strategies for calming, good strategies for doing the right thing, and good strategies for managing the anxiety. And also, not every behavioral aspect of ADHD will totally respond to medication, which means you need to develop good habits. I always tell the families, the goal of our intervention is to develop good habits and avoid bad ones. And if we can do that, you can be quite successful as an adult. In all environments, we know that structure, routine, consistency can be very helpful, and supporting executive functions and learning good executive function skills, which can be done in this population. When medications are used for the management of ADHD, they basically fall into 3 major groups. We have the stimulant medications, which everybody knows about: methylphenidate with the brand name Ritalin, amphetamines, brand name Adderall, Dexedrine, and Vyvanse, amongst other brands. But those are the ones that are most commonly recognized by the community. And they come as long-acting formulations, short-acting formulations. They come as liquid solutions. They come as melt tabs. They come as tablets. They come as patches. There's a wide variety of ways in which we can use them to successfully manage the ADHD. And we know that these medications can be very, very effective to reduce the core symptoms of ADHD, to improve the attention span, reduce the overactivity, and reduce the impulsivity. For some individuals, they may do better with some stimulant medicine, or you may want to add a non-stimulant medicine to the stimulant medicine. Atomoxetine or Strattera, viloxazine or Qelbree, bupropion or Wellbutrin are probably the three that are best known. In the old days, we would also use tricyclic antidepressants for the management, although they're not used as much nowadays. And then there's the adrenergic agonist, clonidine, which is Cadapress, and guanfacine, which is Tenex, is a short-acting form, and Intuniv is the long-acting form. All of these can be very helpful in the appropriate circumstance to help improve attention span and reduce impulsivity. However, as I tell people, when we use medication, the medication can move you closer to the starting line so you can run the race with everybody else, but you have to run the race. The medication does not do that for you, which means you need to develop those good habits, those good work habits, those good social habits, those good educational habits in order to be successful. So the goal of treatment is controlling the ADHD during daytime functioning. We find that many times extended release formulations, ones you take in the morning and last much of the day, if not all day, are better because it gives you a more even effect throughout the day. But medicines should always be used in conjunction with the appropriate educational, behavioral, and or psychosocial program. For children and for adults, there are very powerful programs that can be quite helpful. It doesn't have to be all medication. Now, for adults, what we're looking at this, we recognize that ADHD ultimately turns out to be a disorder of self-regulation and impulse control. We have to hold things together in that way. We know that it can have a negative impact on life activities if we do not intervene. And because it has a negative impact on life activities, including health care and accessing health care, it can have a negative impact on life expectancy, whether it's because you're doing unhealthy actions or because you're taking excessive risks that put you in danger of an early demise. It is clearly a public health issue. There's an increase in healthcare costs that can be avoided if we manage the ADHD appropriately from the very beginning. It has a negative effect on employment. It puts people in prison who do not have to be there, which basically means takes more laborers out of the market, disrupts family units, and increases societal costs. And if we intervene for ADHD, treatment may reduce these risks. So the important thing is recognizing that it's there, recognizing what to do about it, getting it done, and then hopefully what we do see is in the long term, the positive impact of that intervention. If anyone wants more resources, CHADD and the National Research Center has it. There's other places that can also have resources. ADDA and ADHD Coaches Organization are also good resources that are out there. Thank you.
Thank you so much, Dr. Wiznitzer, for your time. At this point, we're going to transition over to the question and answer period of the webinar. We've been getting some questions both in the Q&A as well as in the chat. So Dr. Wiznitzer, and you just covered a little bit of this, but wanted to see if you were interested in expanding because we had just gotten a question in about this. Could you expand on some of the resources that may be available to families or people living with ADHD who were recently diagnosed?
For people who are recently diagnosed, basically, I would recommend using CHADD as one of the resources. CHADD runs the National Resource Center on ADHD, which is a government-funded, non-pharmaceutical industry-funded resource where all the information there is vetted to make sure that it is scientifically accurate and offers a wide variety of different kinds of information. I also recommend that people get yourself a good book to read. And I don't think maybe this webinar is the right way I can give all names of books, but there's a lot of good books about ADHD that are out there. Get yourself some good books about executive function and their management, because as you get older, executive function difficulties, issues with basically organizing yourself, issues with time management can become paramount, that they can be the big thing. And these resources can help guide you. So in other words, you have to understand what ADHD is. You have to understand what the intervention is. And then once that happens, make sure you're working with someone if you need medication so you get the medication used appropriately, as well as working with a psychologist, therapist, or a coach in terms of working on the non-pharmacologic aspects that need to be addressed. There are many other good web pages out there. There's good information about ADHD at many of the web pages of the major medical systems. Also, the organizations such as the American Academy of Child and Adolescent Psychiatry. There's information available through the Developmental Pediatrics Organization. There's lots of good places if you go looking. I would not recommend necessarily doing it on TikTok, unless it comes from a reliable source to start with. Anyone can have an opinion about ADHD. The problem is you got to make sure that opinion is scientifically valid.
Right. We actually just got a follow-up question in the Q&A to the answer that you were just giving. I'll read this here. It's very difficult to find behavioral therapists for young children. What resources are there for finding these individuals?
If I may say something, welcome to my world. If I agree with that questioner completely. That to me is one of the rate limiting steps in that regard. Usually you will find resources at the major medical centers. One of the things I would recommend doing is find out if you live far away from the major medical centers, can you do it by telemedicine? Because that kind of management can be done. But each of the major medical centers and the children's hospitals will offer those resources. There are a lot of good mental health centers that are present in all the cities. I mean, I know best what we have here in Cleveland, but I know around the country we also have it, and you can access those kinds of resources. They're there. CHADD also offers a listing, if I am not mistaken, of mental health providers that can be accessed through that organization.
Fantastic. And another follow-up question to this. Can any provider diagnose ADHD, or should somebody always look for a specialist?
Any provider can diagnose ADHD if they know how to diagnose ADHD. Do you have to be an uber specialist to do it? No. In fact, I would argue that sometimes the big specialists should be there for more of the complex and complicated diagnostic issues. Any well-trained pediatrician should understand the criteria. I do agree that in the adult provider organization, it may not be as good. Obviously, psychiatrists can do it, and so it's true. We just have to make sure when you talk to the provider, how much do you know about ADHD, and you have to ask them, are you comfortable making the diagnosis, or do I basically have to access the resource? This question is probably a bigger issue for the diagnosis of adult ADHD than it is for pediatric ADHD. In pediatric ADHD, I think we have that area pretty well covered. Around the country, there's lots of very, very good resources. And in the adult, for the listeners to know, the adult ADHD guidelines are presently being worked on. APSARD, which is the ADHD Professionals Organization, is working on them in conjunction with CHADD. And those will soon be available and disseminated to the public. I think that will be very good because then we'll be able to train the providers that need to understand how to make the diagnosis and provide more resources to the patient population.
Great. I have a few more questions from you here, Dr. Wiznitzer, from the Q&A. I just want to say to the folks who are submitting questions, we're doing our best, in addition to the ones that Dr. Wiznitzer is answering live, to also answer them in the chat to the extent that we can. But Dr. Wiznitzer, we got a follow-up question for you here on the same topic. Do you see ways that you can educate and loop in primary care physicians to help with screening, medication, referrals?
When it comes to pediatrics, the initiatives are already there in terms of working on that. When it comes to the family medicine providers that take care of children, the same thing. Those resources that are the training programs are there. We did recently had one here at our medical center, and I've talked to the pediatricians, and they were very happy with that. When the guidelines come out for the adult ADHD, there will be exactly the same resources for training that will be available, including training of the trainees. In other words, the people who are now presently working on becoming internal medicine doctors or becoming a psychiatrist and such, so that by the time they finish their training, they should feel comfortable and adept in making the diagnosis and knowing some of the initial management strategies, we'll say, for uncomplicated ADHD.
Dr. Wisner, I'm going to give you just a moment here. I know you've been talking for a good 35 minutes. I want to give you a breath. We're getting some questions in here that I think are more public policy focused that might be good for myself, or Tanya, or Ingrid, or Jeff, our co-chairs of the Public Policy Committee, to weigh in here on. One question, and I'm happy to take this one unless anybody else wants to join in or chime in here. But we got a question. I know this presentation talked about the Public Policy Committee at CHADD. What do they do for people like me? I'm happy to start answering that question. And Tanya, Ingrid, Jeff, if any of you want to jump in, please feel free to do so. We do a lot of work on the Public Policy Committee. We meet on a monthly basis, sometimes more often than that, depending on what subcommittees we're members of. We recently, just in April, went to the Hill and had members with meetings with members of Congress and their staff, both sides of the aisle, as well as both in the House and the Senate, advocating on behalf of people living with ADHD and talking to members and their staff about important issues that are facing those individuals. A big focus of our advocacy during the April Hill Day that we did was talking to members of Congress about actions that they could take to help deal with the stimulant medication shortage that's been affecting people with ADHD like me for at least 2 years now and has been kind of a consistent issue for a while. We also, from more of an administrative regulatory side, we will submit public comments to proposed regulations, both at a federal and the state level, again, advocating in ways that we believe help folks who are living with ADHD, both children, adolescents, and adults across the country. And generally, we just monitor what's going on, and we try to make sure that we're abreast of anything that's happening that could be affecting folks who are in this population and their family members, so that we can respond as necessary to try to advocate on their behalf. I'll pause for a moment, but y'all don't have to jump in if you don't want to see if Tanya, Ingrid, anybody from the PPC has anything to add there.
I always have something to add. The other thing is that the committee is also very focused on children and school-related issues. We recently met with staff members of the Office of Special Educational Programs for the Department of Education. So, our concerns are about how ADHD is dealt with in the schools, both through Section 504 and if the child is receiving special education. And we had a very good meeting with them. They were very interested, as we were able to point out through statistics that of all the different special education categories, other health impaired, learning disabilities, autism, all of these has a high rate of kids with ADHD as well. So they were interested in that. We'll be meeting with them again.
Thank you, Dr. Katz. Tanya, did you have something you wanted to add? I saw you come on camera.
Well, I also wanted to be able to mention that we also work with a mental health liaison group. So we work with a larger community of mental health organizations, making sure that we're always collaborating to ensure that we're cross-covering things when we are dealing with public policy. So we may be dealing with public policy and education. Well, we may be dealing with public policy and ADHD and dealing with parents who need assistance. We may be dealing with our chapters who are wanting to be able to get additional information and want to be able to know what other organizations are doing. So we try to make this be not only the public policy piece, but we're also trying to do the advocacy piece where we are making connections within the communities to be able to ensure that ADHD is really well understood and that people have a better understanding of the services and the information and education that CHADD provides.
Thank you, Tanya. Appreciate you chiming in there. I am looking at the chat and also looking at the clock, and we're coming a bit up on time here. I just wanted to mention that we, I believe, can get a copy of the Q&A after this. So we'll look through and make sure that any questions that we weren't able to answer here live and weren't able to answer through the chat, we can follow up in future email communications and try to get back to folks on. I just wanted to raise kind of one last question because I think it's a common theme that's coming through the chat, which is resources, which I know that Dr. Wiznitzer already spoke about at length in some ways. But whether it's Ingrid, Dr. Katz, Dr. Wiznitzer, Tanya, does anyone want to speak a little bit to the other capabilities of CHADDs or chapter services, some of the resources maybe Dr. Wiznitzer didn't cover, and just talk about what CHADD could do for some folks who might be on this call and asking themselves that?
Well, the CHADD does have the National Resource Center for ADHD, which is funded by the CDC. And if you get on the CHADD, website, you'll see that. They have health information specialists who answer the phone, can answer questions. And if they don't have an answer, they can usually find out. So that is a good resource.
I would,
So
I
much,
would,
Dr. Katz.
I would also encourage anyone who's really interested in getting more involved to look into the CHADD chapters. We have chapters throughout the country that you can absolutely become a member of. They offer support groups, they offer information, community activities in some of those chapters. And so I would really recommend that you consider getting involved with a chapter in your local area.
One of the things that to accentuate what Tanya just said is that once you join a chapter, you talk to other people in the chapter, you find out you're not alone. This is not a unique life experience, thank God, but other people have gone through this. You can get some good ideas, good advice about how do I handle this, what resources are available in the community that I can utilize. And it's much easier working within a group, a support group, that for many people than it is just working on your own.
Absolutely.
Well, thank you so much, Dr. Wiznitzer, Tanya, Dr. Katz, Ingrid, for all of your comments and answering these questions today. I guess I'll ask one last open-ended question, which is, does anybody else have anything to add, anything they want to say before I move towards wrapping this up here?
Can I say one quick thing? I think the listeners have to recognize the gravity of the diagnosis. In other words, the impact it has, not only just for the minute or for the hour or for the day, but over the entire lifespan. And it's a bit insidious. It slowly can, without appropriate intervention, it can slowly eat away at a person's self-esteem. It can slowly eat away at a person's health, slowly eat away at a person's lifespan and life expectancy. And with appropriate treatment and intervention, obviously it has to be recognized, but appropriate treatment and intervention, we can reverse many, if not all of those factors. So while people say, it's just ADHD, so what? It's not really that. It's something that will affect people for decades to come.
Thank you so much, Dr. Wiznitzer, and thank you everyone again. So at this point, I'll move over just to wrap us up. So thank you to everybody who attended today and who participated in this important conversation. As I mentioned earlier, the widespread education of key stakeholders about ADHD is one of our major priorities as a public policy committee. While ADHD may be widely known, it is so often misunderstood, I think to the detriment of children and adults living with ADHD as well as their families. As Dr. Wiznitzer discussed, a growing body of research indicates that people with ADHD are at a higher risk of poor health outcomes compared to the general population, and furthermore, are subject to a shortened life expectancy if they're not treated. ADHD must now be viewed as a public health problem that's producing a substantial impact on the health, the quality of life, and the economic viability of the US population. The CHADD Public Policy Committee will continue to use our platform to educate about ADHD and the issues facing people living with the condition. That being said, our next Lunch and Learn session will focus on another key priority of the CHADD Public Policy Committee that I know was mentioned a few times here today, which is developing US guidelines for the diagnosis and treatment of ADHD in adults. That session is going to take place on Tuesday, September 24th at 12 p.m. Eastern Time. Our team will send out via email more information on that session and how to register, and we invite everyone here to join us once again for that meeting. We mentioned this in the chat, but if you have any questions, comments, or you just want to connect with our committee following our meeting today, please don't hesitate to reach out to us through email. Our email is publicpolicyliaison@chadd.org. That's publicpolicyliaison@chadd.org. Thank you all once again for your participation, and we hope to see you at our next Lunch and Learn on September 24th. Have a great day, everyone.